Good evening and a warm welcome to all the dignitaries present here. I'm Sriushi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event, hosted by the Oncology Integrated Society, and the focus of today's session is latest on radiotherapy in NSCLC. Now I'd like to lighten the lamp and play Ganesh Vandana to give a warm welcome to each and everyone present in this webinar.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Yes.
Thanks everyone for your patience. So let's begin today's session, for which I would like to invite Dr. Diksha ma'am to take over. Diksha ma'am, over to you. You can proceed with the talk.
Good evening and warm welcome to all to this another episode of Cancer Webinar Series under the aegis of Oncology Integrated Research, along with Dr. Chaturvedi Cancer Hospital, Gorakhpur, and the Clarinet team, of course. On this occasion of New Year, let's embrace the pursuit of knowledge as the light that guides our work in oncology. May this year bring us closer to pioneering advancements, compassionate care, and collaborative efforts that transform lives. Wishing you all a year filled with purpose, discovery, and impactful contributions to the field of cancer. Let's make this year a year of learning, growing, and making a real difference in oncology. Here's to new goals, meaningful collaborations, and providing care changes lives. Wishing you all a year full of success and inspirations. Today, we have the President of Oncology Research Foundation and host Dr. A.K. Chaturvedi, who is the man behind this webinar, Senior Oncologist and owner of Dr. Chaturvedi Cancer Hospital, who has been the past President of UPI Roy. We have a panel of expert oncologists who are pioneers and brilliant in their own fields. Dr. Sarupa Mitra from Fortis Gurgaon, Dr. Ayush Garg from SRMS IMS Bareilly, Dr. Sonia Tiwari from Allahabad, and the doctors in the reverse panel, Dr. Vivek Malhotra sir and Dr. Manoj Vastav sir from Lucknow. We have ourselves good speaker, Dr. Himanshu Pruthi, an oncologist from Jaipur, who is an excellent person, a person full of intense knowledge, technical skills in treating types of cancers. And he shall be discussing on the topic of the latest radiation technology, small cell lung carcinoma, NSCLC. Welcome, Dr. Himanshu Pruthi, sir. Once again, we all welcome the dignitaries, experts, participants, and chairpersons with joint palms. Hope this meet bridges a lacunae and enlightens knowledge to the best. Post the session, we'll have discussion and take-home messages. Questions will be put in the chat box so that they shall be discussed at the end of the meet. I hand over the virtual dais to Dr. A.K. Chaturvedi, sir.
Thank you, Dr. Diksha. Dr. Rahat Hadi is also there in the panel. And today's topic is the latest in radiotherapy in non-small cell lung cancer. And as you know, non-small cell lung cancer accounts for approximately 85% of all lung malignancies. And this particular cancer is often insidious, producing no symptoms until the disease is well advanced. Early recognition of symptom may be beneficial to the outcome. Lung cancer is often insidious and producing no symptoms, as you know, until the disease is well advanced, and in approximately 7 to 10% only, the lung cancers are diagnosed incidentally in a asymptomatic patient when the chest radiograph is performed for the other reason. So this is very important. So this is accidental finding. Otherwise, at the initial diagnosis, 20% of patients have localized disease and 25% patients have regional metastasis, and 55% of the patients have distant spread metastasis. And this is the reason why the lung cancer is very difficult to control. Often the common symptoms used to be simple cough, chest pain, shortness of breath, coughing out blood, wheeze, hoarseness, and this stays for a long time. And then it creates a problem. Metastatic signs, they depend upon the site of metastasis. Wherever they go, they produce their symptoms. So today's topic is, as we have already told, latest in radiotherapy in non-small cell lung cancer. And for that, we have invited Dr. Himanshu Pruthi from a consultant, RHL Renova Cancer Center, Jaipur. He has got a vast experience. He did his MBBS from Manipal campus, Manipal University, Karnataka. Then he did DNB from Saroj Gupta Cancer Institute, Calcutta. And thereafter, he was associated with so many good institutes, Medanta, Medicity, the Gurgaon, Medical College, Baroda, and Saroj Gupta Cancer Center, Thakurpukur, as you know. And so many prizes he has got in presentation in different conferences and seminars. So I invite Dr. Himanshu for his discussion on NSCLC. Dr. Himanshu, please. Dr. Himanshu?
Yes. Am I audible?
Oh, yes. Now you are.
Yeah. Thank you so much, sir, for this introduction. So I'm presenting after a really long time, so I'm a bit nervous today. Yeah.
Don't bother. We are all together and we are all of the same platform. Go ahead.
So my slides are visible.
Right now.
No, sir, you have to share the slide once again, sir.
Okay. They're visible now?
Yes, now it's visible, sir. Make it full screen, please.
Yeah.
It's full screen only, right? Okay, I'll start. So good evening, everyone. I'm Dr. Himanshu Pruthi. I'm currently working as a radiation oncologist in RHL Renova Cancer Center, Jaipur, as Sir humbly told. So the topic for today is management of primary lung cancer. I'll be focusing mainly on non-small cell lung cancer. So the contents of the presentation would be lung cancer, a bit about the introduction, clinical presentation, investigation, as management includes both investigations and treatment. So as we know, lung cancer is the most common cancer worldwide. It is the most common cancer in men and second most common cancer in women, just after breast cancer. And the leading risk factors for lung cancers are smoking, secondhand smoke, family history because of the some of the genetic mutations we find in lung cancers, hazardous chemicals like asbestos, radon exposures, etc. Clinical presentation of lung cancers would depend on the type of disease, like whether it's a local disease or is there a loco-regional spread or distant metastasis. Like some common features would be fatigue, persistent cough, shortness of breath, coughing up blood, repeated respiratory infections, back, shoulder, and chest pain. This happens usually when the disease invades chest wall or any nerves.
Dr. Himanshu, can I interrupt?
And weight loss. Then, yes, ma'am.
Can you make the screen a little big?
I'll change.
And just double tap, I think so. It will
wait.
Go in a slide share mode. Now this is better. And to see clarinet team people, can you help them? Help him?
Just a second.
Sir, you just make it full screen. Click on the slideshow option.
Is it fine now?
Yeah, it's good.
Yes, sir.
Yes. Oh.
It's good. Thank you.
So, other clinical presentation for a lung cancer could be a superior vena cava syndrome, which patient usually it's because of the compression of the superior vena cava. Patient usually presents as a facial and be shortness of breath. There would be headache, chest pain, etc. Facial plethora, distending neck, and chest veins. Another not so commonly seen, but paraneoplastic syndromes as well. Like for example, small cell lung cancers can present with ectopic Cushing syndrome, syndrome of inappropriate ADH secretion, neurological syndromes. Non-small cell cancers like adenocarcinoma can present as a non-bacterial varicose endocarditis, but it's a very rare presentation. Squamous cell carcinoma can present as hypercalcemia. Then hypertrophic pulmonary osteoarthropathy is another presentation which we usually see as clubbing. Then all lung cancers would usually have anemia, dermatomyositis, granulocytosis, and some blood derangements. Then coming to the management and investigation and management, we can divide the investigations into three parts: diagnostics, staging, and the other routine investigation. So when it comes to the diagnostic investigations, we would definitely, when a patient comes with such respiratory symptoms, we would usually have a chest X-ray and HRCT thorax. And if we find a lung mass there, then we go further, like with bronchoscopy. And for diagnostic purposes, we definitely need a tissue diagnosis, which would be most commonly a CT guided biopsy or maybe a bronchoscopic guided biopsy, depending on the location of the tumor. Sometimes cytology is also helps. We need cytology for from the pleural fluid as well. Then for the staging workup, there are imaging, of course. So we routinely at our center do PET-CT scan, the first staging investigation. And if you see, some of the guidelines say that MRI brain should be done for every patient, except for early T1N0 disease. But we routinely don't do MRI brain unless there are symptoms or it is a small cell cancer, then we definitely do MRI brain. But yes, some guidelines a lot mediastinal staging. With the advent most these days with a lot of PET-CT scan being done, I have not seen many people doing EBUS and US on a daily basis. But yes, there are times when we do EBUS guided FNA and all when we are doubtful about certain lymph nodes, and it strongly alters our treatment management. Then other investigations are the routine blood investigation, pulmonary function tests. Yes, these are really important, especially when the patient is planned for surgery. Carbon monoxide diffusion capacity as well, cardiac workup. These three tests form a really important set of investigations when the patient is planned for surgery. Then after all the investigations, as I said, CT guided biopsy is required for cancer diagnosis. So what are the major histologies which we usually see, most commonly see is the non-small cell lung carcinoma, which we're going to discuss today, and small cell carcinoma. Non-small cell lung carcinoma is again broadly divided into squamous cell carcinoma and adenocarcinoma. These are the most common histology we see, but of course there are some rare histologies as well. So coming to the staging, so we are still following AGCC 8th edition. I'm sure I know a 9th has also been there now. So the tumor, as we know, is divided into TNM. So T1 is the early T tumor less than 3 centimeter. Just by the, if we go by the size criteria, then we have T2, T3, and T4. Nodal staging is divided again further: 3, N1, N2, N3. And interestingly enough, metastatic stage, that is M1 stage, is also further divided into M1A, M1B, and M1C. And this division has an implication on our treatment as well. I'll talk a bit about that in later. So then, of course, after staging, we have stage grouping. Why I put this complicated table here? Because this stage grouping is one of the factors which help us to decide our treatment. So coming to the treatment part. So treatment of lung cancer is depend on a lot of factors. What treatment we are going to give to a non-small cell lung cancer. So of course, how patient has clinically presented to us, what is the performance status, what is the pathology of the disease, and what is the staging of the disease. So if we say clinical presentation, of course, if a patient is an SVCO patient, so it for superior vena cava or obstructional syndrome, it is a medical urgency, not any emergency anyway nowadays. So we definitely need to have a tissue diagnosis and staging. Depending on that, we will go, if it is a metastatic cancer, we'll go for a SVCO. In non-small cell, we'll go for radiation. If it is a small cell, we just go for chemo. Performance status, of course, because whether we are going for surgery or chemo radiation or SBRT or radiation, patient need to be fit for the treatment. Pathology, yes, non-small cell and small cell cancer differ in their treatment. So non-small cell has a different set of treatment, and small cell we manage differently. Staging, of course, what modality we are using, whether we are using single modality or a combined modality or all three modalities, that also depends on our staging. So we'll slowly see stage by stage how we do. So I'll be dealing with non-small cell mainly here. So as I said, there are majorly three modalities: surgery, radiation. Radiation could be conventional radiation or stereotactic radiation, SBRT or SABR. Systemic therapy, which includes chemotherapy, immunotherapy, and targeted therapy. Then coming to stage-wise management. So for non-small cell cancer, localized NSCLC, let's say it's T1, 3, N0, N1. So if the patient is surgically fit with the good performance status, surgical resection is the treatment of choice for this stage, T1 to T3, N0, N1, that is these stages. And the surgery would be lobectomy along with nodal resection. That is the surgery of choice. But of course, for surgical resection, we need the patient to be of a good performance status, and patient should have an adequate pulmonary reserve. So there are various testings which we done, like pulmonary function test. So we need a FE1 predicted to 40%. Then there is carbon monoxide diffusion capacity. And if there is a borderline function, then we can always go for ventilation perfusion scanning. And apart from this, we definitely need a cardiac clearance to proceed with the surgery. So as I said, I'm reiterating that localized lung cancer, surgical resection would be the treatment of choice, provided the patient is fit and has an adequate pulmonary reserve. Then do we need any adjuvant treatment post-surgery in case of non-small cell lung cancer? Yes, there is a role of adjuvant chemotherapy. There is a role of post-operative radiation as well, but there are very specific indications. So for adjuvant chemotherapy, if the tumor size is more than 4 centimeters, or we have node positive disease pathologically, maybe when we started off, it was N0 clinically, but pathologically it was N1. So, or clinically as well, it was N1 or more. Chemotherapy, cisplatin-based chemotherapies are the standard treatment of choice in such cases. Do we have role for post-operative radiation? Yes, of course we have. So in case of margin positive or as well, and pathologically node positive stage, pathologically N2 diseases, there is a role of radiation. This I was doing a bit of studying. So some of the studies say that we do not need to give pathologically node stages, but most of the standard books as well agree to the fact that for pathological node 2, we need to give radiation as well. And if there are indications for both, so it's preferable to give chemotherapy first, then radiation first. This I'm talking about the protocol which is followed in leads. When they have indications for both chemotherapy and radiation, they go with sequential. First they give chemotherapy and then post-op radiation therapy. But of course, if there is a residual disease, gross residual disease, one can always think of a concurrent chemoradiation as well. Then coming to if in an early stage disease and it is inoperable. Inoperable could be due to fitness, no cardiac fitness not given to the patient, or low pulmonary reserve, what are the treatment options we have? In case of an N0 disease, we can go for SBRT or SABR, that is stereotactic body radiotherapy or stereotactic ablative radiotherapy. It largely depends on the location of the tumor, what doses we are using. And if the patient is not fitting for SBRT or SABR, then we can of course go for conventional section radiation with concurrent chemotherapy as well. So again, a bit about SBRT and SABR. So as I said, location is very key when we are looking for, when we are planning for SBRT. So this picture I've taken, you can see the tumor is very much peripheral, more towards the chest wall. It's not central tumor. So these are the cases which we easily take for SBRT, SABR. But does that mean we don't take other central or mid lung tumors? No, we definitely do them as well. So our dose schedules depends on the location actually. So like this is one study which was published in 2008, and a lot of centers in the UK follow these protocols. Not exactly, but more or less around this. Like for middle lung, they try to give 60 grain 3 fractions, 60 grain 5 fractions for the next to chest wall. But when it goes towards the center, the central structures, they increase the fractionation. But of course, this 60 grain 8 fractions, we usually, when we are doing at our centers, we don't do for central lung tumors currently in our center. But there are other schedules for central structures as well. But why are we so worried about the central structures? So as per the Timmerman trial, so the tumors within the 2 centimeters of the proximal bronchial tree, that is considered as no-fly zone. So we don't give SBRT there initially when the concept of SBRT came. But these days there are trials, like one such trial was central lung SABR trial. So it was a randomized phase 3 trial, phase 2 trial in preparation for randomized phase 3 trial. But the trial could not be done because of it was closed due to poor recruitment. But then there is an RTOG 0813 trial, which showed a 5 fraction regimen, and a 10 to 12 gray per fraction protocol can be used. And when I've done 1 or 2 cases in my previous institute when I was doing my DNB. So we did one case where we did 50 grain 5 fraction. We didn't go for within 1 centimeter airways. That is according to this trial, we did around the tumor was around 2 centimeters. So yes, so not a lot of people would recommend unless one is very expert in SBRT for central lung tumor SBRT. Then are there any trials for SABR versus surgery? Yes, there are 2 small randomized trials. So as you saw, I had previously shown that we do SBRT for early stage inoperable. But are there any trials when the lung cancer is inoperable and we still do SABR? Sometimes patient refuses. So there are 2 small trials, Rosette trials, and one more trial is that. So they have compared SABR versus lobectomy in early stages operable lung cancer. So there were phase 2 trials. The patient accrual was not good. So further trials are in process. So currently for an early stage lung cancer, it would be better to go for surgery only if everything surgical criteria is fit into. But there are trials head-on-head comparing coming up. Maybe in near future we might we might take operable patient for SABR as well. Coming to one key technical aspect of SBRT, we definitely, as we know, lung, we are breathing. So lung, there would be movement in lung tumors. So we are giving a very high dose through SBRT. So we need a good motion management system as well for our lung cancer SBRT. So there are various options like respiratory gating, there is abdominal compression, there is 4D CT scan, etc. Uh, so at our institute, we have RPM system, variance RPM system. You can see there's a camera, there is a detector I've shown with the arrows. And with this, we do our respiratory gating. So we get these kind of graphs, and we can do into DIBH mode, that is deep inspiratory breath hold, or we can do gating as well. And the other option which we have is 4D CT scan. So 4D CT scan is basically when we are adding a fourth time parameter in a 3D scan. So we get a full picture. The scan is divided into multiple phases, and then we generate our treatment volumes based on the 4D CT scan. This is another way of doing it. But most of the cases which we are doing in our centers are usually by gating, respiratory gating. Then these were the other picture which I have not put here is abdominal compression. This is also a way that we can actually do SBRT. A lot of time patient is not able to perform respiratory gating, like he's not able to hold breaths and everything. So abdominal compression is a tested technique for respiratory dampening. So I've seen when I was again doing my PG, some of the institutes doing it, and they had good results with it. Then coming to locally advanced non-small cell lung cancer. Again, the treatment there would be radiation, concurrent chemoradiation. It could be sequential chemoradiation. It could be concurrent chemoradiation followed by consolidated chemotherapy. And if the patient is not fit for chemotherapy or the combined modality, we can go for radiotherapy only. So coming to the concurrent chemoradiation part, the standard dose which most followed is usually 60 grain 30 fractions. For concurrent chemo, there is no single regimen that could be considered standard. Of course, these days everybody is using weekly carboplatin and paclitaxel. So the two doses which you would usually see in the trials would be EP, that is cisplatin etoposide at a systemic dose, where cisplatin is given at 50 milligram per meter square per day, and etoposide is at 50 milligram per meter square, given on day 1 through 5, and then the 2 other days. And and the weekly doses are also there. If we are not going through cisplatin and etoposide, the full systemic dose, we can go for weekly doses as well. That is carboplatin with AUC2 and paclitaxel at 40 to 50 milligram per meter square. And if we are following this weekly regimen, then there are 1 or 2 trials I was going through today. They say that we need to give 2 more cycles of full systemic dose of paclitaxel carboplatin as a consolidated chemotherapy. Then coming to immunotherapy, do we have any role of immunotherapy? We know, of course, for stage 4 cancers and advanced cancers, we have immunotherapy. There are many trials for that. But do we have immunotherapy in locally advanced non-metastatic? Yes, there is specific trial and the immunotherapy in use there is durvalumab. So I'll take a bit on this trial. So it is a trial for concurrent chemoradiotherapy plus immunotherapy. So the patients were taken here with stage 3 unresectable non-small cell lung cancers who have not progressed following platinum-based concurrent chemoradiotherapy. They were randomized 2:1 in durvalumab for 12 months and a placebo. As I said, they were non-operable patients. They were mostly stage 3 patients, deemed inoperable. Other criteria was the good performance status, no evidence of progression post CRT, and no unresolved toxicities. And their patient was commenced on durvalumab treatment within 40 days of completing chemoradiation. So as you can see, the median overall survival for durvalumab was 63.1 months, and for placebo group was 29.6 months. So it definitely showed a benefit, and more towards patient with the PDL1 more than 1%. So yes, if you see NCCN guidelines, they have also added this trial to their recommendation, but for the treatment. Then coming to a very specific type of tumor, superior sulcus tumors, or as we know, PANCOS tumors. So do we have any different treatment for them? Because a lot of time you would see non-small cell cancers as superior sulcus tumor or PANCOS tumors. So again, if the patient is operable, in this case, usually it's a T3 or T4 tumor. If the patient is deemed operable, then trimodality treatment is one which we can try for superior sulcus tumor or pancreas tumor, but the patient has to be deemed operable before starting the treatment. And if not, then of course the usual non-small cell lung cancer treatment, that is concurrent chemoradiation. When I say trimodality treatment, that is a combination of chemoradiation followed by surgery. That is neoadjuvant chemoradiation followed by surgery. And nowadays, even Checkmate 816, which adds chemotherapy, immunotherapy to the trimodality as well, has been there for as a part of trimodality therapy. Otherwise, the pancreas tumor usually they differ in their presentation, but the treatment modalities are more or less same as the other non-small cell lung cancers. Coming towards the end of my presentation, so stage 4 disease. We usually have systemic therapy. I'm not going into the details because it's not my expertise. We have chemotherapy. If we are going for non-small cell squamous cell carcinoma, usually people would go for paclitaxel carboplatin as the treatment regimen. Adenocarcinoma chemotherapy would be pemetrexed-based chemotherapy. Then we have so many trials for immunotherapy, pembrolizumab, durvalumab, etc. Then of course we have targeted therapy, and targeted therapy, there EGFR inhibitors like uh, uh, osimertinib, etc. Then we have ALK inhibitors, ROS inhibitors, crizotinib, etc. So I'm not going into the details because that itself is a whole uh, array of treatment. Then other indications of radiation in non-small cell lung cancer, as I mentioned initially, superior vena cava syndrome. So patient usually presents with breathlessness or facial puffiness and headache and all. So radiation works really well in superior vena cava syndrome. And as I mentioned, it is not a medical emergency anymore, or an oncological emergency rather. It's an oncological urgency. Then of course, a lot of time patients, metastatic patients would present as malignant cord compression. So radiation, of course, has a role there. And brain mets, definitely. A chunk of our patients are stage 4 patients with brain mets, and the option for brain mets we have, depending on the metastasis, we have stereotactic radiotherapy, or single fraction radiosurgery, or whole brain radiotherapy. Some people try it with boost as well. And of course, radiation has a good role in palliation of symptoms as well. So, cough, chest pain, hemoptysis, radiation works wonders with this if, in an advanced stages patient. Some of the recent advances, which I've not gone into the detail, but I'll mention, is there is an oligometastasis and oligoprogressive diseases, and immunotherapy with SBRT and SBR. These are some of the recent advances. So oligometastasis is there for quite some time now. So uh, suppose we have lung cancer locally advanced and we are doing CTRT, but there is a single brain metastasis. So we can actually give SRT to that brain metastasis and treat the lung cancer as per the standard regimen. So so that those trials and those studies are coming and they are showing promising results. So oligometastasis is one thing which can be looked for, and not even not only just for the intracranial, extracranial single mets can also be considered as oligometastasis, and we can do SABR or other localized treatments. Like suppose if there is a single liver mets, we can go hepatic resection or hepatic uh, metastatic resection, or SABR to the liver mets, etc. That's why, as I mentioned in the stages, initial staging part, so there is M1A, M1B, and M1C. And if you go to AGC 9, they have further divided M1C into M1C1 and C2 now. And then there's another upcoming field is that interaction. If you go back to our radiobiology and everything, how radiation interacts with the immune system. So nowadays there are trials coming up. I've seen some phase 2 trials. iSaber is one of them, with the combination of radiation with immunotherapy. So maybe there are coming up there are upcoming trials. So in near future, will we have some phase 3 trials? They might become some standard of care for non-small cell lung cancers as well. So that was all for my presentation today. Thank you so much. And before saying anything else, I would really like to thank Chaturvedi Cancer Hospital and Oncology Integrated Group to give me this opportunity so that I can talk in front of you guys. Thank you so much.
Yeah, it was a very brilliant talk by
Thank you.
Dr. Himanshu in such a short span of time with all excitements and everything. Dr. Ayush, will you like to add something to this? Hello.
Yes, well, first of all, congratulations to Dr. Himanshu for giving such an excellent presentation.
Thank you. Thank you, Dr. Ayush. Thank you so much.
So, just one point, like I was going through, like when we are giving for borderline operable cases of stage 3. So, in those cases, we can there are trials which have shown results in neoadjuvant chemoradiation.
Yes,
So
sir.
that is also an option where we can go ahead with neoadjuvant chemoradiation. And along with that, as you correctly said, that Checkmate 816, so it added nivolumab. So even now, many centers are practicing neoadjuvant immunotherapy.
Yes,
So
sir.
it has shown proven results that it is better than only chemotherapy. So, and you very well said that there is no clear-cut consensus regarding whether we should go ahead with sequential chemoradiation or we should go ahead with concurrent chemoradiation. So that is still a dilemma, but usually what we practice at our center is we give one cycle of chemotherapy and then go ahead with concurrent chemoradiation. So
Yes,
eventually, I think every center with time they will evolve with their own protocols rather
yes,
than depending upon the Western literature. Because in our Indian scenario, we don't usually see lung cases in such early stages.
yes, sir.
Minimum what we see is stage 3 advanced or stage 4.
Yes, sir.
So so that is a big challenge when we go through the Western literature. So
The-
once again, I'll congratulate Dr. Himanshu. It was really a very nice presentation.
Thank you.
That's very right. We are not getting early stages, that too very small in quantity. Sometimes we
Yes,
get
sir.
1 or 2 cases in a year. So that
Yes, sir.
it becomes very
Yeah,
difficult. I think
I
we
to
should make a committee, or rather, we should sit together and form a consensus on trial, and we will collect all the cases at one
yes,
point and then present. So that will be a
yes,
collective effort for that. है ना? Dr.
yes,
Rahat
sir.
Hadi is Professor RML, Lucknow.
Yes.
Your comment? You are muted, Dr. Rahat. Ah, now it's okay.
नहीं अभी भी
No,
नहीं
we are not able to listen to you.
Okay, now you
Yeah,
can
now.
hear?
yeah
Yeah, now it's okay.
Sir, as you have rightly said that we are not seeing the early patients.
Mhm.
Early stage patient we are not seeing, and Dr. Aish also tell us about the same thing. And it is the real scenario that we are getting this lung cancer patient in very advanced stage. And they only came to us for palliation therapy.
That's the only thing left.
Not for any radical or curative intent. है ना? So this is a little bit drawback, and it depends on center to center also, sir. Once I was in KGMU, there was pulmonary medicine department. So we are getting the cases there right now. But here in RML, only very few cases we are getting.
Actually, for the early diagnosis, you have to have something in our mind to diagnose that. Otherwise, they are misdiagnosed.
mindset चाहिए
Yes. So thank you, Dr.
and
Rahat. Dr.
Dr.
Sonia.
yeah
Dr. Sonia. She is consultant at Kamla
Illahabad.
Nehru. Yeah.
Good evening, sir.
Allahabad.
Yes,
Haji, good evening. Your photo
good
is not
evening.
coming.
Yeah.
They're not able to see you.
You have become muted or what?
Yeah, I think
You
so.
disappeared.
Yeah, just now she had done a very organized a very big UPRI at
Yeah, you're
Hyderabad.
right. Conference at Allahabad.
Yeah,
Dr.
all,
Rahat Hadi was there.
yeah, we all had enjoyed.
It was very nice.
meeting.
Ma'am, but we miss you there.
Actually, my hand got burnt na.
Very,
Diwali.
little bit sad
Yeah.
thought of you.
Hi,
Yeah.
Sonia.
Now
Do
it
you
has
comment?
improved.
Now it's okay.
Hmm.
You are
Yeah,
muted.
hi.
Now you are okay. Yeah, ma'am.
Hi, good evening
Dr.
and
Sonia.
Happy New Year.
You are
You're
muted.
muted
You are
here.
muted, Dr. Sonia. Unmute yourself. Yeah.
Yes, hello.
Yeah.
Ha, sir. Good evening.
Very
Your
good evening.
opinion.
Yes. Ha, that's very
You comment.
insightful lecture. That is true that you all are saying कि lung cancer mainly detect in a very advanced stage, but in our many treatment modalities are there, targeted therapy nowadays. So survival is improved as compared to previous because of the good EGFR therapy and the immunotherapy with the, but these therapies are very costly, so cost is one of the issue in our scenario. So still with the simple drugs, paclitaxel, pamitrexate, some of the patient respond well. After that we can take the patient for chemoradiation, so but they are very few as we know. But yes, what will be we can do, we do. But this is a very good insightful lecture, so thank you so much.
Thank you. And thanks to the PMJ so that people are able to afford those medicines.
Yeah.
Otherwise,
Yes,
they used to
yes.
die without medicine.
Otherwise, yes,
This is very good thing
yes,
that through
yes,
PMJ, most of the people, most of the cancer patients are getting treatment free of cost.
yes,
And now
yes,
higher end machines are available in every city.
yes,
So
yes.
this is another advantage. So even if we
With
get
the
in early
IGIT
stage,
and with this uh,
we can treat.
Yeah.
breath.
Dr. Sarupa also was going to join, but she is in traffic. She was
अच्छा,
saying कि MRI वाली लिनिया
yeah.
उनके यहाँ है for
MRI
better.
लिनक लगा लिया है उन्होंने.
हाँ,
Congratulations.
हाँ, for a better compliance and
हाँ,
treatment. Anyway, तो अब नहीं है जो तो क्या करें, rare
क्या
चीज
किया?
है. Thank you, Dr. Sonia, for being so sporting and joining us at the 11th hour. I just thought it to make it a bit more fruitful and enjoyable. And so we have lost sight of yours. Connection lose hai lagta hai kahin. Anyway, so
Thank you so
doctor
much.
will give a concluding remark and take home message.
So
Dr.
this is
Chaturvedi.
so as you know, NSCL early stage diagnosis is difficult, but in if we get the cases in early stage, you can treat it with SBRT, IMRT, any external beam therapy. Plus proton therapy can also be used, although centers are very few, one or two centers are there in India, but the results are quite good as they are explaining, but we don't know, we have not experienced. So right now what is available with us is our tools, LINAC and chemoradiation or immunomodulators. So they can be used freely and hope will give a better result, and with the hope that we'll collect the cases from different centers and make it a combined effort to publish the things. Okay, so we'll find out something. This is the platform where we can add on.
Yes.
There's no problem.
Hmm.
So thank you so much. Thank you everyone for joining us. Thank you.
Thanks, Dr. Himanshu,
Thank
Dr.
you so much.
Ayush, Dr. Sonia, Dr. Hadi Rahat, and many others who wanted to join but couldn't do it, and the effort of the clarinet team. Thank you all. Thank you, Dr. Diksha, for debut in this 2025 as an anchor. And thank you, Dr. Himanshu. It was really nice to add last moment so many trials, and it was really wonderful and awesome. And we all gained a lot from it.
Thank you. Thank you so much.
Thanks a lot. Okay.
Thanks for all joining, Dr. Rahat.
Thank you, sir.
Thank you.
We'll hear you
And
again.
I
Give us some
appreciate from your
topic.
effort also.
Yeah.
Thank
Yeah.
you so much. Thank you.
Give us
We are
some
trying to
topic,
bring
Dr.
all the
Rahat.
medical and radiation oncologists together.
Yes.
medical, surgical, and radiation oncologists together on this platform. And this is the
Yes.
purpose, just like
Yes.
ISP.
Yes,
Yeah.
sir.
Okay.
Okay, so we take your leave and a happy
Night.
new year once again. Sweet dreams and good night, everyone.
Okay.
Okay.
Bye, ma'am.
Thank you so
Bye.
much, everyone.
Bye.
Thank you so
Bye.
much for giving us the opportunity to host the session. Thank you.
Thank you.
Thank
Have
you.
a nice day to all of you.
Thank you.